Hi, I'm Simran, the Senior Radiology Registrar. I got roped in last minute by Andrew Clark and Scott Andrews to do this talk, and now that I'm here, got a microphone, I understand why they didn't want to come. The title of this talk is Radiology Trauma Quiz, and therefore it's a quiz component. I would kindly ask for participation. If I had more time, I would have developed an app and it would have been an interactive, anonymous thing, but I don't, and IT is not my strong point despite my complexion. If it was, I wouldn't be doing medicine. So anyway, we'll go through a few cases. I've only got half an hour. If they're too easy, I apologise in advance, and you can take this time to just rejoice and perhaps some self-meditation. So this is and ideally this room would be pitch black, but it's not. This is a 25-year-old who, I'm joking, had a motor vehicle accident, come in a quad bike. So I'm just going to ask if anyone can see any significant findings at all. I'll give you time to digest it. And just to help you guys out, I've even got options here. So the first option is that pulmonary contusion, is a pneumothorax, and I don't know if you can read that, but it says skeletal injury. So you've got three options. Anyone take us for, there's more than one correct option. Anyone go for number one? Sweet, okay. Anyone for number two? Ooh, not so sure. Anyone for number three? Supine view, yep. Okay, so everyone's happy with pulmonary contusion. Okay, I'll just go through this. So yeah, you can see that there's an ET tube down here. It's probably a portable film, so it's supine. There's consolidation bilaterally, and in the setting of trauma, that's probably going to be pulmonary hemorrhage contusion. And on the supine film, the sensitivity for detecting a pneumothorax is low. Because they're lying down. But one sign that you can see is a deep sulcus sign. And what you actually do notice is that there's quite a deep sulcus size on the right, and the left side it's normal. And that's highly suspicious for a pneumothorax in the setting of trauma. And I'll just show you the CT to tell you, make sure that we're not lying. So you can see the axial slices lung windows. And what it shows, they do indeed have a pneumothorax here. They've also got lots of pulmonary contusion. You can see with consolidation. There's also an area of cystic sort of airspace in here, and often when the lung lacerates, it recoils, and then what you do get is little areas of cystic change or blebs. So that would be consistent with a pulmonary laceration. But also what they do have, and this is quite hard to see, and I don't think everyone will walk past this, is actually got a bit of some osseous fragments down in the thoracolumbar spine down here. That's very helpful to have this arrow. Unfortunately, our images don't come with arrows. And what they actually also do have is a fracture involving the thoracolumbar junction, as you can see. And this fracture involves the vertebral body. It goes right through the posterior elements, and there's widening of the interspinous process. What we can characterize this as a three-column fracture, and a chance fracture is what we'd call it. And as you can see on the axial CT, there's a lot of fragments that have been retropulsed into the spinal canal, and I assume the spinal cord is not very happy. This is the same case of the patient. Does anyone know any associations with a chance fracture? This is a quiz component of it too. Oh yes, Mr. Cox. Very good. You guys have done your pre-reading. Very good. Has anyone seen any abnormality on this axial CT? It's a tough one. Yeah, I like how you guys are there. So there's pancreas here. It doesn't look too bad. That's the liver here. Yeah. So what this CT shows is that, unfortunately it's a bit bright, but there's a liver laceration involving the liver. It's characterized with linear hypodense area through here, and there's probably a bit of hematoma. The pancreas looks normal, and you'd worry about that in a chance fracture. But they've got locules of gas here, you can see. Now this comes on to the sources of pneumoperitoneum in trauma. Anyone got any ideas? Four possible sources. Bowel, yep, that's the most common. Yeah, I won't give you that one, but yeah. Good, yep, pneumothorax. Yeah, and any sort of trauma, yeah. Yeah, they can. Yeah, it can occasionally track up the vagina and it gets out the fallopian tubes into the peritoneal cavity. It's very good, off the book, I like it. Anyone else? The other possible sources are so pneumothorax, you've got your perforated viscus would be the most common cause. The other cause is the pneumomediastinum, so you can have gas tracking from the chest down through the retroperitoneum into the peritoneal cavity. And the other one you can also get is a pseudopneumoperitoneum, and this is sort of a new thing we're discovering with CT improving in resolution, is that you can actually have locules of gas by the intercostal spaces here. And what the thought is when you have blunt trauma, the chest wall compresses, it's very compliant, and bubbles of gas leak out of the costochondral joints. View. Oh, yeah, I agree that you can't see it, but I guess if you windowed it, you can just get the bottom to it. But yeah, you ideally want to see C7 or T1 to clear the cervical spine. So we get an adequate view. It's not much better. But what this shows, and it's very difficult, is if you follow the anterior spinal line, it's a little bit funny at C2, C3 here. And then it's a bit harder to follow the posterior line. And the C2 vertebral body doesn't look normal. I know these are not diagnostic projections, but you've got to take my word for it. So this person went on to have a CT scan, and what it shows is that they do have a fracture of C2. There's retropulsion into the spinal canal here, as you can see. And these are the soft tissue windows. So you can imagine that the spinal cord, say you get a bit of the cerebellum, this is the spinal cord in the spinal canal here, and it's causing mild vertebral canal stenosis on the CT, but you can't, as you know, fully evaluate the spinal cord on CT, and if there's any neurology, they should really get an MR. And my limited experience, often the neurosurgical and orthopedic people will get an MR, particularly if they're thinking about fixating the spine. I'm just putting in the other CTs just to, just to show you that we're not lying, and also it's nice to look at different modalities. Any questions at all, feel free to ask at any time. I'll do my best to answer them. So this is the same patient, and this shows you an actual view of one of their vertebrae. Does anyone see anything that they would worry about if they kind of saw this? Go for it.
You've got a fracture into the vertebral foramen.
Yeah.
And your vertebral artery comes up through there, so there's a high associated risk of dissection of that artery with that injury.
Yeah, that's right. So often when I'm on call and I have a trauma, I always make sure I look at the transverse foramen in a C-spine injury, because what that means is, do you know what we can go on to do then? CTA, yeah. So we go on to do a CTA, and that means, changing slightly the way the protocol runs. We have to, basically give them contrast earlier and then scan the neck again. And what this shows is the contrast CTA. You've got your lovely internal carotid arteries here. You've got your right vertebral artery here, but you've got no contrast within the left vertebral artery. So this would be in keeping with a traumatic injury to the left vertebral artery. And often, because the vertebral arteries are very small, you don't often see a dissection flap like you might do in other vessels. So it's hard to know exactly what the mechanism was that caused it to occlude, but I guess it's irrelevant, but it's occluded. So that's a little bit about traumatic vertebral artery injury. You can have different, it can be, thrombosis, an intimal tear, or dissection. The absence of any neurology doesn't mean to say they don't have a dissection, because you've got, assumingly, a normal artery on the other side, and the basilar artery supplies the cerebellum, so you can have compensation through that. And there's been evidence out there that shows that even people with normal neurology can have vertebral artery dissection. And it's most commonly injured in the C6 to skull base as it goes through the foramen, and particularly as it does the hair bend around C1, it's prone to a dissection. This is just a lovely diagram, I think, that just depicts the vertebral artery. I can never remember the segments, so this is like one of my go-to diagrams. I can give you a copy if you're really interested. And this is just to show you an MR of what the potential complications are. This is a different patient, but you've got T2, and you've got what we call a stir. It's a fat-suppressed T2 sequence, all the fat suppressed. And it's very good for showing any edema. And you can see that the cord here has got high signal within it, so it's, there's myelopathy, so damage to the cord. And also there's some bit of low signal on the T2, so you worry about hemorrhage in the cord too. And you can see this is a diffusion-weighted sequence of the brain, and it's the most sensitive sequence to look for stroke. It'll pick it up within minutes. And it shows you there's an area of high signal on the DWI in the right cerebellum, which fit with an acute stroke in the setting. So, and there's also they've got a pre-vertebral hematoma here. And they've obviously done some damage to the posterior soft tissues. And we've had recently a case, actually, someone dissected both their vertebral arteries after going to a chiropractor. So, yeah, I wouldn't advise that. Okay, our next case is a motor vehicle accident. I'll give you guys a few minutes to digest the subtle findings on this plain film. So I'll give you some options because I'm a nice kind of guy. And the options are, is this aspiration pneumonia? Is this a large pleural effusion? Is it a hemothorax? Or is it collapse of the lung? So, who goes for aspiration pneumonia? Nobody? Good. How about pleural effusion? Oh, no takers. How about hemothorax? Few takers, few people. And how about collapse of the left lung? More people. Okay. Does anyone see a reason why the lung may be collapsed? It's pretty unusual just to collapse the lung in blunt trauma. Yeah, ideally if the left lung does collapse, you get some shift of the trachea. Ideally, yeah. Yeah, that's right. So it's pretty hard for you guys to see, I understand, but there's an ET tube here and it's peeking into the right main bronchus. Yeah, that's right. Got ya, no. And then, so therefore there's collapse of the left lung. But I mean, I like what Mr. Cox said. Ideally what you just get shift of the trachea. You should have done radiology, Mr. Cox. It's not too late to change. What you could probably see is some narrowing of the ribs. So if you look at into space between the ribs, and here they're not so, it's not so much of a gap. So you can say there's collapse of that left side. And we get to it whenever you have a chest radiograph. You look at your line and tubes first. So they removed the ET tube. And now you can see that there is a re-expansion of that left lung, maybe still a bit of collapse of the left lower lobe. They've also put a central line in. So a good rule of thumb is if there's an ET tube in and the patient is supine, it's a mobile FIM, you ideally want the ET tube around the heads of the clavicle, because once you take in movement at the head, particularly when they're supine, then the tube can drop down a lot further. So if it's about the level of the clavicular heads here, then you can say it's pretty safe. If they're in a standing radiograph, then you probably want it a bit lower. It's kind of what we use as a guideline. I'm sure other people have different thoughts on that. Any questions? Pretty straightforward. Next case. This is another case. I'll give you a good clinical history. Trauma.
It's usually all right on the film for you because we don't really have time to run on it all.
Yeah, that's why I see trauma. Yeah. I'll give you some options. So, is it a diaphragmatic rupture? Oh, confidence. I like it. Is it an empyema? Where they're really sick, then crash their car. Is it left lower lobe consolidation? Or is it a poor inspiratory effort and therefore it should be repeated? It feels like everyone thinks it's A. Anyone have any other thoughts? Any strong feelings? Yep, you guys are right. So what's a giveaway is the nasogastric tube, really. You can see that it comes down and then it goes up, and it's not right. And you've obviously got a lot of opacity here, and you could say, I mean, in a different setting, this could conceivably represent empyema. You could have a pleural collection with gas within it. But all this stuff is colon up here. And this is a CT that just demonstrates the fact that the stomach is herniated up through the diaphragmatic defect on the left side, resulting in keeping with a traumatic hernia. And the thing about diaphragmatic ruptures, often it's a result of blunt trauma, so you've got increased intra-abdominal pressure, diaphragm gives way. It's more commonly on the left side than the right side, and the thought is that the liver acts like a buffer, so it kind of protects the right hemidiaphragm. And often the chest radiograph is normal initially, and people often present delayed, and I've seen cases where people have had diaphragmatic hernias and they didn't even know about it. I guess they're pretty stoic and didn't go to the hospital, but they definitely had a ruptured diaphragm and then come in for some other, indication like lung nodule follow-up, and then they've got a, diaphragm rupture. So they can present late and they can be missed initially. Oh, next case. It's a young person with trauma. This is a hard one, because you guys I underestimated you all. I apologise. I'll give you some clues. Is it a pneumothorax? This is a erect radiograph. Is it a pneumomediastinum? Is it a normal chest x-ray? I could be tricking you. Could be. You never know. Is it a mediastinal hematoma? Okay. Who goes for pneumothorax? No, one person. Pardon me? Oh, good, man. I like it. Pneumomediastinum. Few takers. How about a normal chest x-ray? Oh, no one. I really want to say it says normal now. Is it mediastinal hematoma? Yeah, it's a tough one. I guess ideally in pneumothorax, you'd see the visceral pleural line, and the lung markings go out symmetrically. You can miss a pneumothorax on a film, and sometimes an exploratory view helps accentuate the pneumothorax, and you can pick it up on that. The mediastinal contours are pretty good. There's no paratracheal abnormality. The aortic outline looks normal, so that would go against a aortic injury. And I don't know if you can project very well, but these can be pretty sneaky, and there's a little linear lucency that runs along the heart here. I'm sure it's probably not very projecting very well, but that's basically air that's outlining the mediastinum. So sometimes you'll look at the heartboard and you look, oh, that just doesn't look right, it's too lucent. So what you need to look for is this air basically sort of lifting into the mediastinum, basically gives you this linear density. And if it's a pneumopericardium, what you look for is basically a bit of gas which lifts the pericardium, the parietal pericardium, and you see a density down here. A pneumopericardium won't sort of extend up traditionally because it's at the root of the vessels. Just because of pericardium, it doesn't allow it. So this is a pneumomediastinum. And I guess another thing is I've got a bit of gas in the right side here, just a bit of subcutaneous gas, which you kind of see in a pneumothorax, but you can't see it in a pneumomediastinum. And often you can see lucency tracking up the neck. So that's another good thing to look for. And just to confirm, they had a CT, and this helps delineate further. You can see there's all this ectopic gas up in the neck, and then there's that little thin linear lucency stripping through here, and that's kind of what you're seeing on the plain film. And just to show you that, so you basically got gas here, and it's in the mediastinum along the front, and this goes on to the. Does anyone know sources of pneumomediastinum, just in general? Esophageal rupture, yep. That's one. 2, Mr. Cox. I should have brought a stamp. Bronchial, yeah. Anything else? There's another thing that's kind of, I guess it's benign, but I think it's probably one of the more, just in general, that can happen. And it alarms people, but the patient's generally pretty well. So, post-operative, yeah, that's always a good one. The possibilities are esophageal rupture, which is a good one, and often you'd see a pleural effusion in that because you get fluid leaking into the pleural space, and often the patient's really unwell. Another cause is basically you can have any bronchial injury. So anything that lets air leak out basically of the mediastinum. So you're thinking what contains air? The bronchus, the trachea, the esophagus. Those are the main ones. Other ones you can get is you can get actually just if a little alveoli pops, sometimes the air can track through the bronchovascular interstitium and basically track into the mediastinum. So often people who are asthmatic, often people who have done strenuous exercise or lifting, they can pop alveoli, and basically the air can track into the mediastinum. So it's not uncommon to have it seen in asthmatic. And this person was actually doing some strenuous lifting at the time and then developed some chest pain and came into hospital. So kind of goes along with it. Initial thought this was a ruptured esophagus, but the clinical history didn't quite add up, and this is reassuring that it's not. Sometimes we can do on-table swallow CT, so we give them a bit of oral contrast before we scan the chest, just to kind of, I guess it's kind of like a CT barium swallow in some ways, just to answer the clinical question. Next one, this is actually a recent case I had on call. This is a trauma person, and this is sagittal CT. I'll give you guys a few minutes just to digest the image. The options are, is this bowel injury? Is it mesenteric injury? Is it bladder rupture? Or is it an L4 fracture? Okay. Anyone go for an L4 fracture? No one. Anyone go for a bladder rupture? Few takers, few people. Anyone go for mesenteric injury? Cool, I like it. Anyone go for a bowel injury? Yeah. So this ended up being a bladder rupture, and it's a tough one because I've only given you one sequence. Ideally, I'd have the whole scan for you to scroll through. But what you can see is that the bladder is really abnormal. It's really thickened, it's heterogeneous, and a normal bladder doesn't look like that. And if you've got fluid in it, it should be very thin-walled. The bladder's not good. You can't assess really the bladder wall on CT, but that's very abnormal. And there's all this fluid around it. And it does raise, is this actually a mesenteric injury if you've got, if you've got fluid within small bowel loops, or is it, a small bowel injury? With a small bowel injury, what you'd ideally see is locules of gas. And the L4 fracture is just to put you guys off. Does anyone know what we could do next to further evaluate this? Or what you guys would do? What would you guys contrast? Yeah? A cystogram. Yeah. So ideally what would happen is if it was safe to put a catheter in, you'd put a catheter in and get them back and you'd do a cystogram. And we did that. And what you can see is basically just inject contrast into the catheter and see where it goes, sort of like a fluoroscopic cystogram. And you can see that there is a contrast leaking out of the bladder, particularly anteriorly, and there's a few locules of gas in it. So this is in keeping with a bladder rupture. And the two main important ones with a bladder rupture is whether it's extraperitoneal or it's intraperitoneal, and that changes management. And in terms of CT, extraperitoneal, what you'll see is you'll see fluid around the bladder, and you'll see extraperitoneal fluid, so you see around the base of the bladder. And you wouldn't see it going up into the upper abdomen and around bowel loops. And intraperitoneal is when you get free fluid in the upper abdomen. You'd also get it through the mesentery of the small bowel. And sometimes you get a combined injury. I thought this was a combined injury, but it ended up being an extraperitoneal one. Oh, this is another one. This is a pedestrian struck. This is quite a tough case and quite interesting. But does anyone see anything on the plain film? Any fractures or dislocations? Nope. Good. So this person went on to have a CT, and I've never seen this before. But does anyone see? These are axial slices from top to bottom of the pelvis. Does anyone see anything abnormal at all? Yeah.
It's all this stuff here that's not over there.
Yeah.
Sometimes you can avulse your abdominal musculature off the
Yeah. Mm.
So it's
Yep.
a bit low down there.
It is a bit low down. Any other takers? Any other ideas? Just to describe it, there's a lot of, I guess you could call it fat stranding or added density in the subcutaneous soft tissues. There's a bit of a high density here too, which I guess could be acute blood or could be extravasation of contrast, given that it's a contrast-enhanced CT, and it's overlying the greater trochanter. That's a big clue. So that's not a bad thought. This is actually, I've never heard of this before. It's called a Morel Lavallee lesion. And essentially what it is, it's a closed degloving injury in severe trauma. And what happens is subcutaneous fat and basically gets stripped off the underlying fascia. And what you can end up having is a potential space, and that gets filled up with hemorrhage and lymphatic fluid. And it can kind of look like this. And the classical location is over the greater trochanter. I guess there's quite a bony prominence there and susceptible to trauma. And I've, in my limited reading of 30 seconds, they supposedly, don't do very well managed conservatively, and they need surgical, drainage. I'm not sure if anyone's got experience in this, if anyone's ever encountered this. No? Anyone?
The problem is they strip the perforators so you get decreased perfusion to the tissue overlying it. But you also can have huge amounts of blood loss, particularly our larger patients. These can be really occult because they're so big to begin with, and it's under such a layer of fat that you can have a lot of blood lost into the tissues without realising that that's the source.
So essentially it's called a Morel Lavallee lesion. So I think if you could take anything away from the talk, this would be this word. I think it's a great word. It's basically a closed decloving injury in trauma. You get shearing of the subcutaneous space, you get a basically potential space, and it fills up, and it's pretty typical around the greater trochanter. And in my pan scans, this will be my first review as a greater trochanter to diagnose one of these. It would give me great satisfaction to put this in the comments at the end of the report. I'll just do one last case. This is a really tough one. So this is another person who's had trauma. This is their this is their lateral and peg view. Does anyone see anything abnormal about it at all? My approach to sort of playing films is I count down to make sure. Anyone at all?
It's a big gap between C1 and C2. And it's an odd shape.
Like in here? Yeah. There's something not right about this, is there?
You lose your normal pre-vertebral shadowing there.
Yeah.
It's got pre-vertebral, probably got a pre-vertebral hematoma there.
Yeah, there's something not right about it. It's hard to put your finger down on it, but you know it just doesn't look right. And so we end up getting a CT, and what it basically shows, this is the occipital condyles here. This is C1, so this is where the occipital condyles would sit. And basically, they've subluxed one side. I'm not sure if this is the left side, I think. And then the right side of the alignment's not quite normal. So this is like a cranioaxial sort of dissociation injury, and can be, this is normally seen in the setting of pretty severe trauma, and they can be pretty subtle to see on the plain film. And I know plain films are sort of obsolete nowadays with, if someone comes in major trauma, but it's still worthwhile being able to sort of see what the abnormality is, and often we just go to CT anyway if there's any clinical concern. That's actually the last case, I have to say. This is actually, I lied. This is actually just a case showing these bilateral perched facets. This is an extreme flexion injury in someone, and this is another case where you do a CTA to make sure that there's no abnormality, so you can see that the alignment is way off. This is a severe flexion injury. And I heard that the orthopods need to put extreme weight on the skull to sort of put it back in place. Is that correct? Yeah. That sounds very painful. Cool. Thank you. This is a chap that discovered X-rays, if anyone wants to know. 1895. So thank him for radiology if you want.
Useful now.
Hey?
And still useful
Yeah.
now.
Cool. Thank you very much.